you need to make sure that the documents that people have submitted best fits the job specification.
All right, hello, welcome everyone. Welcome to today's session. Today is session 8 of Oxygen Therapy and Critical Care, the case-based series. Today we're going to be talking about high flow nasal cannula and non-invasive ventilation with our esteemed panelists. So I will hand it over to Dr. Eunice to start us off.
Hello everyone. My name is Dr. Eunice Ngatia from Tigoni. I think I've been with you for most of the sessions. So I hope most of you have not forgotten what we have learned so far. So it will just be mostly building up on what we have been learning over the couple of months that we've been doing the series. So I think maybe we can just dive right in and then we start the session. Am I audible to everyone?
Yes, we can hear you.
Okay. So we have our patient, maybe larger. I'm trying to see. Try and enlarge the screen.
Is it legible now?
Yes, I think so. Okay. Okay. So Mr. G, so we're going to go through, as it is always, it's a case-based scenario, and then we'll be able to discuss. So our topic today, we're going to go through the high flow nasal cannula, oxygen delivery system, and we're also going to do the non-invasive ventilation, just touch up on it. So our patient, we have Mr. G, who is a 38-year-old male. He presents with tachypnea and hypoxia. So as we've said, a high flow oxygen therapy and an invasive positive ventilation for adult patients. So, so this will be the objectives for this teaching today. So with the high flow oxygen therapy, we want to understand the upper limits of low flow devices, which we have already covered. We covered them in the other session, and we'll just go through them and see what is the lower limit. Then we're able to differentiate between low flow oxygen therapy and high flow oxygen therapy, understand when to escalate to high flow oxygen therapy, list proposed benefits of high flow oxygen therapy, list possible complications of high flow oxygen therapy, understand how to up titrate high flow oxygen therapy, and understand how to down titrate high flow oxygen therapy. And the good thing about these objectives, most of them we've been able to touch on them when we are doing the other presentation, so it will be easy to go through them. So for the non-invasive positive pressure ventilation for an adult, we list the indications for non-invasive positive pressure ventilation for acute respiratory failure, then list proposed benefits of non-invasive positive pressure ventilation, and list possible complications for this. Down. So we're going to go to, so we go to our case now. So Mr. G, he's a 39-year-old, presented with 5 days of worsening shortness of breath and dry cough. His breathing is harder when he gets up and walks around. So he has tried to stay in bed and rest. He has noticed that his fingers and toes are blue. Well, his breathing is becoming worse. So in his past medical history, Mr. G has a BMI of 35, so he's obese, and has type 2 diabetes on oral hypoglycemics. Past surgical history, he has had an appendectomy at the age of 20, and he has no allergies. Okay, scroll down. So he works as a house painter. He's divorced. One son aged 10. He does not smoke. He drinks beer on the weekends and occasionally drinks, okay? So for the high flow, so this part now, so keep the case scenario in mind. So as we are going into the discussions. So for the high flow oxygen therapy, and also for the non-invasive positive pressure ventilation, you have to bear in mind that you need a PPE for contact because it's likely to have droplets and airborne. So you always have to have your PPE on, so you avoid getting infected, as opposed to the low flow oxygen delivery methods. They do not generate as much aerosols, so they're not likely to be as contagious as when you're using high flow. So of note is that you always have to wear your PPE, and even if it's not the full gear, you just have to wear your mask, especially a good protective mask for you, okay? So we want to understand the upper limits of the low flow devices, differentiate between low flow oxygen therapy and high flow, and understand when to escalate. So from the questions, which low flow delivery devices deliver the highest FiO2? Which low flow oxygen delivery devices deliver the highest FiO2? Maybe you can put the answers in the chat box. Sarah, is there a poll or they'll just do the answers in the chat box?
There is a poll, but it's not working. So go ahead and put it in the chat box.
So kindly put the answers in the chat box so that we can move. So from what we have been discussing, the low flow oxygen devices, so which offers the highest FiO2? Yes, I can see. Yes. Okay. Okay. Thank you. I've seen people are putting in their answers. Good. Yeah, everyone seems to have the correct answer. So, someone says that they can't hear anything. Okay. So from our previous discussions, as we alluded to, nasal cannulas, we have a flow of 2 to around, some people can push up to 5 liters per minute. Simple face mask goes from 5 liters to 10 liters. Nasal catheter, we'll discuss that. A mask with reservoir, it does 10 to 15 liters per minute. Venturi mask also does up to 10 liters per minute. So the correct answer is D. Okay, so we can continue. So for the case update, Mr. G has the following vital signs. His temperature is 38 degrees Celsius. His heart rate is a bit on the higher side, 99. His BP is 107/88 and a tachypnea of 28. His saturation is 90% with a face mask with a reservoir of 15 liters per minute. So from this, list signs of respiratory distress in an adult. I think we've done this quite a number of times. So if you could put in maybe your responses very fast, a few responses in the chat box, we see. And even just from Mr. G, what are we seeing? What kind of respiratory distress is he having? Maybe we can have a few responses. Anyone? Thank you. Can see someone saying tachypneic and he has low SpO2. Okay, that's actually one of the main things we can actually appreciate from this patient. Okay, but there are other signs that we had talked about initially. Use of accessory muscles of breathing. You will see some intercostal recession in some patients. Some will be dyspneic, completely dyspneic. So all these things are measures in which you check the respiratory distress. So we can continue. Yes, I can see someone pale, fingernails, breathing difficulty, nasal flaring, wheezing. That's all true. Okay, so we have a video here just to illustrate how Mr. G is. Just try and pick up as many signs as possible. You can write what you see in the chat box. Notice how he's breathing. Look at the intercostal spaces. See that there is some recession. You can see there's tachypnea, use of accessory muscles. So this is definitely a patient who has respiratory. This will actually call vent failure. Okay. Okay. So a question, true or false? High flow nasal cannula is oxygen delivered through a standard nasal cannula at a flow greater than 6 liters per minute. What do you think? Is that true or false? Kindly put your answers in the chat box. Is that true or false? Thank you, Dr. Mohammed. I can see false. Okay, so this is a false statement, yeah? So it's not the standard, we don't use the standard nasal cannula, but they are almost similar, but you'll be able to see even in the video, they look different. So let's go down. So this is how a high flow nasal cannula looks like. Almost the same concept of, it almost looks like a nasal the nasal prongs that we are used to, but you can note that it has a connecting circuit that connects it to first a humidifier, and then also there's one that's connecting it to the oxygen in the wall. So even at the humidifier, we'll notice the difference is this one goes through a humidifier. You can be able to set the various parameters that you'll be able to set from the high flow nasal cannula. And even the amount of flow that you're going to put for this patient is going to be different from what you use in your normal nasal prongs. So do you want us to go down? Okay. So yeah, but let's watch a small video. Sarah, the volume?
Is the volume not working?
Oh, now it's okay. Just try. The volume is not working.
The volume of the video is not playing. Is it working now?
I don't know, can anyone hear? No, I can't hear.
Zoom might not be letting the sound go through then.
Wow, okay.
Is it working now?
No. Unfortunately, it's not working.
And I don't think the sound is going to work for us today. This video is available on the Learning Resource Center for free, though, that participants can go back and watch it in their own time after the session. I'll share it in the chat as well.
Okay, you can share it. I'll I'll go through it since I had watched it and just give them the highlights of the video.
I'll just let it keep playing and you can talk over it, Dr. Eunice.
Okay. So in essence, as I've said, the high flow therapy, the main thing is you're going to use a higher flow of oxygen, which can range from 20 to 60 liters per minute, but most people will prefer setting between 20 and 35 liters per minute. Another thing is the air is humidified, so you also set the temperature for you to humidify the air as it is passing. And then you're also able to set the FiO2. So those are the three main things that you'll be able to set in a high flow nasal cannula. And as you put in, you're supposed to put in a tight fit when you're putting in the patient. So there's a way you adjust at the back so that it can give a proper tight fit to the patient. And then you're able to titrate, even the flow of the oxygen and the FiO2, depending on how the patient is responding. You can start initially, give it some time, and then see if you need to increase. And even if the demand for the patient is adequate, you'll be able to see it from your parameters. Then you'll be able to either decrease the settings or you're able to increase the settings. So you'll be able to see that in the video. So for this case, despite receiving oxygen by mask with a reservoir, which we had noticed earlier, his initial SpO2 was 90. So we're saying he continues being fast breathing, he continues having tachypnea. His respiratory rate has now increased to 36, and his SpO2 has fallen to 88%. The bedside provider decides to place him on a high flow oxygen therapy. So let's continue. So list the proposed benefits of high flow oxygen therapy, list possible complications of high flow oxygen therapy, understand how to titrate high flow oxygen therapy and how to down titrate. So what do you think are some of the benefits of using high flow oxygen therapy? Maybe you can write for me in the chat box. Is there a benefit? Like with the COVID, are there people who've been able to use the high flow oxygen therapy? So just write in the chat box to see at what the advantage is. Are there any benefits? Can we give you like a minute? Mm-hmm. Are there any benefits of using high flow oxygen therapy? Mm-hmm. So it has an increased FiO2. That is true. Assist the distressed lungs to function well. Okay. Someone else? We've mentioned something very specific that you can set in the high flow as opposed to the low flow. Does the humidification help in anything? Mm-hmm. Thank you. Improved perfusion. So in general, we'll say, okay, improves alveolar ventilation and it decreases dead space. True. Okay, so I think you're getting, so let me just go through some of the benefits. So some of the benefits is the nasal cannulas are small pliable nasal prongs. They're very soft and they're easy to put on a patient. Then the fact that you're able to humidify the air, the flow is very high. So the air that goes in is already warm. So it means that these patients also have, the advantage of already humidifying, so the patients don't dry up. And then as we've noted with COVID, these patients have a lot of secretions. So if you're giving some warm air, it helps in loosening the secretions. So you're actually able to even remove, so the patient is able to have a lighter mucus instead of having the thick. So it's able to, you're able to remove the secretions easily. And then of course, as you're saying, since it's humidified, you're able to avoid epithelial injury. So washout of nasopharyngeal dead space. So as you know, there is the dead space. that's usually in the nasal pharynx. So you're giving continuous air. So you're able to, that dead space is actually, instead of being the normal FiO2, the one that we breathe that has 21% oxygen, that dead space has a higher fraction of inspired oxygen. The other benefit is, since you're giving the flow is very high, you're giving some sort of continuous positive airway pressure. This enables the alveoli to remain open. So, which in essence means you're either recruiting more alveoli, and even the alveoli that are there are already remaining open so that you're able to create a greater surface area for you to be able to have gaseous exchange. And as you remember, even from the last topic, when we were talking about ARDS, we talked about the importance of having CPAP. So I hope you remember that. So, and then the high flow rates result in minimal entrapment of room air. So this results in more accurate oxygen delivery. Since the nasal cannulas fit in and go directly in the nasal, in the nostrils, so you see there is no air that is being entrapped from the environment. So you're giving it directly. So whatever amount that you have set, if you've set a flow of 30 liters per minute, you know, you're actually delivering that. And the FiO2 that you have set is exactly what you're delivering, as opposed to the low flow where you actually entrap the environmental air, which ends up diluting the amount of oxygen you're delivering to the patient. Okay. I think those were the main benefits that we have with high flow. So list the possible complications of high flow oxygen therapy. Sure. Do you want to write some of them? Any complications you will think of? Okay. Okay, I like atelectasis. Okay, absorption. Interesting concept, okay. Anyone else? Okay. So the complications, formation of radicals, that is true. As we said, oxygen is a drug like any other. So you can actually, the formation of oxygen radicals is very true. Barotrauma is there, though the risk is not as high, but it's actually one of the risks of one of the complications. Yeah, so maybe we can read all of them. You'll be able to scroll. So as you're saying, you're going to put this high flow nasal cannulas in the nose, yeah, in the nostrils. So it means if you have any facial deformities, so all these patients who have facial deformities and you may not be able to, abnormalities or any surgery to the face and nose and airways, so, and they can't have, because you see you put it and then there's a way you tie it at the back. So any patient who has any abnormalities or any surgery these are patients who are not good candidates for this high flow oxygen therapy. And then, as we said also, there's a risk of barotrauma, but it's not as high as with mechanical ventilation or with the non-invasive ventilation. So those are some of the main things that were the complications. So it's generally a very safe tool to use. It's easy to use also. Once you learn how to do the settings and everything, it's one of the easiest and safest tools to use, especially during this COVID, before you're able to step up the patient to use now to go to non-invasive ventilation or intubate the patient. It can be a go-to as you wait in between, waiting for the patient to go to the next stage. Okay, let's continue. So this is a subcutaneous emphysema with a small right-sided pneumothorax in an adult with ARDS. And okay, yeah. I also noticed we used to have a lot of subcutaneous emphysema, but mainly with ventilated patients. You will find it patients having the use of the CPAP and who are intubated. Intubation not as much, but with the CPAP, we noticed a lot of subcutaneous emphysema. Okay. Scroll down, Sarah. So what are the 3 parameters that must be set in the high flow oxygen therapy device by the bedside provider? I've already mentioned this. I think I've insisted on it. The first thing you have to set is the temperature so that you can humidify the oxygen. Then you have to set the flow, the oxygen flow. We've said it ranges from 21 to 60 liters per minute, but most people you always start with 20 to 35 liters per minute. And depending on the need of the patient, you can either increase or decrease depending on how the patient is responding to your therapy. And then also you set the FiO2. So the FiO2 ranging from 21 to 100%. So depending on how the patient is responding also, you'll be able to titrate those 2 things. So I hope that's clear. Maybe Sarah can type for them. We said temperature, FiO2, and the flow, the oxygen flow. So those are the 3 main things that you're going to set in a high flow oxygen therapy. Okay. Thank you. Let's see if the video will play. I hope it plays. And the volume.
Is the sound not coming through still, Dr. Eunice?
I know, but it's okay. I think I've been able to already explain what is in the presentations.
Great, we'll just skip it then, and I'll put the link in the chat.
Yeah. So list the indications for high flow oxygen therapy. Maybe, and they're just, they're there. They've actually been put very well in the diagram. Maybe you can scroll up and then enlarge a bit so you can see. So we're saying high flow oxygen therapy will be used in hypoxemic respiratory failure. That is a very strong recommendation. As we said, like Mr. G, he was not improving on the 15 liters of face mask. So he's a good candidate to actually put on high flow oxygen therapy. So following, what else? You can actually do following extubation. This, there are some conditions that you have to meet, but they've actually studies that have actually shown that patients who have immediately after extubation and then you put them on high flow oxygen therapy, you're less likely to reintubate them as opposed to the patients who you just go straight to low flow oxygen therapy. So that can also be a step down measure from intubation or use of high flow like CPAP, and then you go to the high flow nasal cannula, and then you go stepping down. You can go gradually. Then you can use it also post-operatively in high risk or obese patients, cardiac or thoracic surgery. These are patients whose oxygen requirement tends to be high post-op. So you want to maintain the oxygen high. So this is also another indication. Then there is another one, there's a peri-intubation period. There was a study that was, you will be sent for the link, that was saying that during the peri-intubative period, where normally you give the patient oxygen, and when the patient's saturations are at 100%, you remove the face, you usually remove the bag and mask, and then you try and intubate. So there was a study that had shown that if you continue if you put the high flow nasal cannulas during that period when you're trying to intubate, they were saying the outcomes were better. But with this, remember, we are in a COVID situation already. This patient, you're already going to generate a lot of aerosols, and even the intubation itself is a high risk for you. So that's why we're saying it's not highly recommended, but maybe in patients who ideally do not have COVID, maybe it would work if you're trying you're also trying to be safe. Because remember, at the end of the day, we said your safety comes first. So you also have to take care of yourself. So we're really not going to encourage that practice. Okay. So you're going to send you the link to this, and you'll be able to read more on it. So from what we have learned, which of the following is incorrect regarding the parameters set by the providers when delivering high flow oxygen? So which one is incorrect? So providers can use respiratory rate to estimate the initial flow setting needed on the high flow oxygen therapy device. Providers can directly measure the flow at which a patient is breathing and match the inspiratory flow demand of the high flow oxygen therapy device. The average inspiratory flow of an adult breathing at rest is 20 to 30 liters per minute. The flow rate set by the high flow oxygen therapy should attempt to meet or exceed the patient's demand. And then E, inspiratory flow demand increases during respiratory distress. So maybe I can have some of your answers so that maybe we can go through this part, since I think we skipped it. We skipped some of the things during the video. Okay, I've seen one person has tried. I need more people to try. I'll give you another minute. Just go through the responses we see. Okay. So I can see many people have written C, which is true. Thank you. So when you were talking about setting the, we said we are able to set 3 things in a patient. 3 things in the patient. So those 3 things will depend on the clinical appearance of the patient. So different patients will require different settings. If the patient is obviously, so what you're going to go for in this patient, as I said, the flow of the patient, when you set the FiO2. So we'll prefer to set a flow rate first of typically of 20 to 35 liters per minute for most patients. But you're going to put this and then you will observe the patient. You'll give the patient time and see is the tachypnea. So the tachypnea will also depend. If the patient is severely tachypnic, you may want to start the settings on a higher flow rate as opposed to the lower flow rate. The FiO2 as well will also determine how the oxygenation of the patient is. If the patient is oxygenating maybe in the higher, maybe in the higher 80s, you're not going to put this patient on an FiO2 of 100%. You may want maybe to just titrate, start maybe with around, maybe say like 70. And then as you continue increasing. And the flow rate can be increased by 5 to 10 liters per minute if the respiratory rate fails to improve, and oxygenation also does not improve, and the breathing remains labored. So you will observe these things and then see how to titrate against the patient. So in a normal patient who is sitting and is at rest, they will not need this much oxygen. So the answer is actually C. A normal patient a patient who is at rest, it means they're not laboring, they're not tachypnic, they will not require oxygen that is this high anyway. So the answer should be C. And then even when you're setting, as we are saying, when you look at the patient, you're supposed to always try to match the need of the patient or slightly exceed their need so that you can be able to be at always, you've been able to compensate for the deficit of the patient. And remember, if the patient is in severe respiratory distress, it means their requirement increases automatically. So our answer will be C. Okay. Continue. So, in which of the following scenarios would providers need to escalate care from high flow oxygen therapy to either non-invasive positive pressure ventilation or intubate with mechanical ventilation? So in which of these scenarios do you think, like after maybe we've put the patient on high flow oxygen therapy, do we need to escalate? Because there are times where it's not enough. So in which scenario do you think we should be able to escalate? So A, respiratory rate does not correct or stabilize despite receiving high flow rates on the high flow oxygen therapy. B, the patient's partial pressure of carbon dioxide remains elevated or worsens on arterial blood gas analysis despite receiving the high flow oxygen therapy. C, the SpO2 does not correct or stabilize despite receiving high FiO2 and the high flow oxygen therapy. D, the partial pressure of oxygen does not correct or stabilize despite receiving the high flow, high FiO2 on high flow oxygen therapy, or all of the above should lead to escalation of care without delay. So what do you think? Let's see your answers. Okay, I can see everyone, people are saying all of the above. Okay, thank you. So in all of these scenarios, you're going to need you're definitely going to need to step up this patient. So once we are on this, it has failed to work, we need to escalate. So that is what we are going to do to look at next. Okay, so Sarah, the answer is E. So all these scenarios, we need you to escalate. So just maybe a cap on this. No, it's okay, we're done with that. Sarah, maybe you can scroll down. There's a question that just will touch it lightly because we had already done this on the last time when we did the ARDS topic. So what is the ROX index and how can it help clinical providers? So ROX index is defined, if you remember, we did the FiO2 ratio when we did the FI ratio during the ARDS. And we said, if you do not have the blood gas analysis, you can use your SpO2. So the ratio of the SpO2 to the FiO2 that you're using to the respiratory rate, that gives you the ROX index, and then it gives you, it's a predictive value of if you need to escalate the care of the patient. The likelihood of you needing to escalate the care of the patient either is to increase the oxygen or to intubate this patient. So that is what the ROX index is used for. It's more of an predictive value. So like we were saying when we did ARDS, It shows you between, is it moderate, severe? So it helps you to calculate that. So it shows you what's the normal SpO2, what FiO2 are you giving, and then what's the respiratory rate. Then the value that you get is going to be a predictive value, like how are you going to clinically manage this patient? That's the main thing about the ROX index. So you see low risk of intubation if you have an SpO2 of 95 and a respiratory of 15. So that is how you're able to calculate this, and it guides you. Okay. I think I just wanted to make sure I mentioned that. So let's continue. We are short of time. So Mr. G remains on high flow oxygen therapy with the following settings. So his temperature is 37 degrees. It has decreased from 38. FiO2 of 100% on 60 liters per minute. After 2 days of initial improvement, his SpO2 is 90%, and he is more tachypnic with a respiratory rate of 35. He appears fatigued, and his arterial blood gas analysis reveal the following. He has a pH of 7.27, so he is acidic, and has a partial pressure of carbon dioxide of 58 and partial pressure of oxygen of 60. So the carbon dioxide is elevated and the oxygen is low. So the bedside team decides to put him on non-invasive positive pressure ventilation. Let's continue. So for the non-invasive ventilation, so we're going to do this, it's just a short presentation. So as I'd mentioned, there's the PPE droplet. All non-invasive ventilation and the high flow oxygen therapy, they generate a lot of aerosols, so you have to be very careful, and you always have to be in your mask, protect yourself from any infection, because the likelihood of you getting infected is very high. So always remember your safety first. Okay, maybe we can scroll up. So for the non-invasive positive pressure ventilation, we list the indications for non-invasive positive pressure ventilation for acute respiratory failure, list proposed benefits, list possible complications. So the good thing about this, most of the things we've already discussed, so it will be a quick. Okay, so let's continue. So so there's this question, what's the difference between NIV, CPAP, BiPAP? So is there like is there a link to it, sir? Okay, maybe let me just talk about it without, it's okay. So for this non-invasive ventilation, what we are saying is you're going to give most of them, there are few ways in which you can deliver this. It can be through a tight fitting mask. We can have some hoodies. There are some that you can have a hoodie of oxygen that gives a positive pressure. It can just be a simple mask that is giving the positive pressure. So we have the two are differentiated mainly that One will be a CPAP, giving continuous pressure, which at the end of the day, we said it wants to end pressure. So what it does, continuous positive airway pressure mode, it gives constant pressure. So the main thing it does is it tries to always keep your alveoli open. So it increases the lung volume, it increases the intrathoracic pressure. So, and the difference with like something like BiPAP. BiPAP gives pressure both times, during inspiration and even during expiration. So it so even when you're trying, when the patient is inspiring, you're giving some pressure, which it either increases the volume and the lung expansion of the patient. So you're able to inhale more, or your lung capacity increases. And even at when you're expiring, there's still some pressure, which also still maintains the alveoli still open for these patients. So there are different indications why you would choose one over the other, depending on which patient you have. Okay, let's go back to the I was hoping this will play. Let's see. Maybe you can press the CC as it's talking. So as I was saying, CPAP tries to maintain the alveoli open. Okay, maybe just let's go through the video. Maybe put a pause on that, Sarah. So of note is some of the things that when you're using CPAP, we're saying it creates positive pressure. So it increases gas exchange by recruiting alveoli, and mainly used for type 1 respiratory failure. So cardiogenic pulmonary edema, congestive heart failure, pneumonia, and sleep apnea. So what it does, especially even in, as you're giving the positive pressure, what happens since the alveoli has some sort of edema or water, quote unquote, the pressure helps to push out the water so that the alveoli stays without the water. So like in sort of way, the pressure pushes out the water so that you leave the alveolar dry and you're able to increase the surface area for oxygen exchange. So that's why you use CPAP in patients with congestive heart failure mainly, and patients with pulmonary edema. Okay. We can continue. Put a pause on that. So far, I think we're going to send the video to you, then you can be able to watch it again. So we're saying the non-invasive ventilation, it gives a push behind every breath. It creates positive pressure. It's used for type 2 respiratory failure, COPD, pneumonia, post-extubation in ICU. You can also prevent intubation in ICU. So this gives, we've said it's the difference with using this is, as opposed to the CPAP, it just gives pressure throughout. So you have pressure during inspiration and pressure during expiration. So this is what we are mainly using in the ICUs, especially for the COVID patients, if once they fail on high flow oxygen therapy. Can continue. So put a pause. So you'll notice, as we are saying, in this patient, we are going to put first, the patient has to be a patient you don't want to, as we are saying, it's a patient who is awake. Patient already has some sort of respiratory effort, like severe respiratory distress, but the patient is alert and you don't want to intubate this patient. So what you're going to set on the machine, since you're saying that you're setting two types of pressure. So you're setting the PEEP, which is the peak and expiratory pressure, and then you're setting the inspiratory pressure. So for this patient who you're using the NIV, the tight fitting mask, you're going to set two types of pressure, the inspiratory and the pressure during expiration, which is the PEEP now. Okay. So maybe we just pause. Something of note when you said there, we said that since you'll set these two pressures, it means at any time given, if you've set like maybe your PEEP, we said like maybe at around, we said patients with ARDS, you're going to give them a higher PEEP. So that is when you set on the ventilator, you'll always notice that it never goes, when you see the curve, the one that was being drawn there, that curve, you'll notice that it never drops below what you have set as the PEEP. So any pressure you set as the inspiratory pressure, it will be like that 15 is pressure above this CPAP pressure. That will be the total inspiratory pressure for this patient. So that is very important, even when you're looking at the curves. But I think most of you will always have someone who will help you to interpret the curves, even when you need to escalate to this level. Okay. Just put a pause on that. So this is the summary of the difference between CPAP and the NIV. CPAP just gives it's high flow with PEEP, positive and expiratory pressure. It recruits alveoli, it corrects VQ mismatch, and it's mainly for type 1 resp failure. For the NIV, you're going to have an inspiratory push, which will be plus the PEEP now. So you're going to have pressure both during inspiration and during expiration. And so this helps to increase your tidal volume, and you're also going to decrease the CO2. So, and this is used mainly for type 2 respiratory failure. And in both settings, as we've said, you're going to titrate according to how the patient is responding. If the patient is responding well, you can decrease the pressures as you go along, and even the FiO2. Okay, continue, Sarah. So, I don't know if Dr. Rachael is there. I think she wanted to say a word.
Okay, thank you, Eunice, for
she wants to summarize. Session. Thank you. Yeah.
Yeah, I think I can take over from here. Thank you for the informative session that you've had. You've done a tremendous job to at least explain high flow nasal cannula and the earlier part of non-invasive ventilation. So I'll start by first wishing everyone Happy New Year. Sorry, I was a bit caught up in the OR, but I just finished, so I'm more settled to now continue. So we'll continue with this part for the non-invasive ventilation, whereby there are two conditions leading to acute respiratory failure in adult patients that have very strong evidence of benefits in the non-invasive positive pressure ventilation, which has been described above. This is the CPAP and the BiPAPs, and what are they? So you have two major conditions that usually respond very well to this mode of ventilation, and that's the acute exacerbation of COPD and acute cardiogenic pulmonary edema. So in COPD, we prefer the bilevel one because here we want to, in COPD patients, they have increased CO2 levels. So this bilevel, having a pressure at the inspiratory phase and both at the expiratory phase will increase the tidal volume, and hence will have more, you'll have CO2 being blown out. So in COPD, bilevel tends to work better in patients who have the acute exacerbation. And also you have the benefit of reduced mortality. It also reduces the rates of intubation and may also reduce the length of the hospital stay. In contrary, in the acute cardiogenic pulmonary edema, as Dr. Ngatia explained above, when you have a pressure, a continuous pressure throughout the face, what you're trying to do is to dry out the lungs so that you have an increased surface area for oxygenation, both for oxygen and for CO2 to come out, and you're trying to recruit the alveoli that have been, that are mixed in the water, in the edema, so to say. So CPAP is preferred here because you have a continuous pressure throughout the cycle. You have the reduced intubation risk, reduced dyspnea, and also reduced mortality. This non-invasive pressure ventilation modes are also very good and important. It's important to note that they need to be performed in a patient who is responsive and a patient who will understand what you're going to do so that they don't keep fighting the ventilator. And as they fight the ventilator, this will affect the mode of treatment. So the patient needs to be cooperative and needs to be spontaneously breathing. Can go down, Sarah. The contraindications. So the contraindications of this mode of ventilation, absolute contraindications if in a patient who requires urgent intubation and mechanical ventilation. That's like in patients who have a cardiac arrest or respiratory arrest. That's an absolute contraindication. A relative one is patients who have facial or neurologic surgery, trauma, or deformities on the face, and probably, or even in the nasal cavity, and they're not able to perform adequate breathing. Upper GI bleeding, encephalopathy, need for prolonged mechanical ventilation, because it's not advisable to, it may not be adequate if a patient requires prolonged mechanical ventilation. Inability to cooperate, patients who are not able to protect their airway or clear secretions, patients with obstructed airway, there could be a tumor or a foreign body. Sorry, can go down. So Mr. G is placed on non-invasive positive pressure ventilation for 1 hour with a pressure support of 15 and PEEP of 5. His FiO2 is set at 100. His respiratory rate remains at 35 breaths per minute. He appears fatigued, he's slumped over in the bed and arouses only when shaking. What is the appropriate next step in Mr. G's care? So you've put him on, this is the bi-level mode. So he has a pressure support of 15 and PEEP of 5, but you're still noting that the respiratory rate is increasing and it's at 35. It's still high, it's at 35, and the patient is not, he's fatigued. What would you do next? You can go down. So this shows that he's not responding to this mode of ventilation. So the immediate course of action would then now we need to think of intubating this patient, so that eventually, if he continues breathing like that, he'll get respiratory fatigue. So it's important to just consider the next action, and which should to be intubate this, to intubate the patient. So these are just a circuit showing the mask types and the filter placement on both the CPAP and the bi-level, which Sarah can share the link and you can go through it at your own time because it's a bit detailed, but it's just how you connect the circuit, both in the non-invasive mode of ventilation. You can scroll down. So she'll share this link in the chat box. You can go down completely after the diagram. So I think we've come to an end of this informative session on high flow nasal cannula and non-invasive positive pressure ventilation. So at this point, I'll ask if there's anyone who has a question before, or anyone who requires a clarification. Okay, I guess it was well understood. So I want to take this opportunity to welcome one of our new panelists who will be joining us in the next, from today. He joined us in today's session, but will be there in the other following sessions. Maybe he could say something before we wind up and close. Dr. Anthony Mulu, kindly say something to the participants. Is he there?
Yes, he is. Maybe just.
Maybe he's having network issues. So I want to take this opportunity to appreciate all those people who are able to join today's session. Thank you so much for creating time. I hope you guys really have learned something out of it. We don't take it for granted, and I hope that as we continue with these sessions, we are becoming better clinicians and better clinicians in our judgment, in our everyday practice. Also want to take this opportunity to thank assistant International through Sarah. Happen, and also university for bringing up these resource sessions so that they can be able to join in the next sessions. So thank you once again. I can hand it over to Sarah, and have a lovely evening.
Thank you, Dr. Rachel, and thank you, Dr. Eunice, for that very informative and incredible session. That was very helpful. So as Dr. Rachel said, please join us next month for the next session in the series. And everything that you saw today, as you saw in the chat, will be available for free on the Learning Resource Center. So please go make an account and you can access all the videos and all the resources, and all of the curriculum that you saw today is open access for anyone to see. If you would like to join our WhatsApp group, you can scan this QR code right here and stay up to date on what's going on. And then join us for session 9 on February 4th. We'll be talking about pediatric considerations for oxygen in critical care. If you have any questions, please feel free to email us at echo@assistinternational.org. And again, a big thank you to our panelists for leading today, to ECHO India for making this possible, and Assist International, Stanford University. It's wonderful to be a part of the things going on here. So thank you, everyone. Let us know if you have any questions. Otherwise, we will see you next month.
Thank you. All right. Good night, everyone.
See you. Happy New Year.